Good evening and thank you for joining us. You're watching Sunday Interview with me, Grevazio Zulu. Starting this month end, public service workers and those in formal employment will part away with 1% of their salaries to help finance the running of the health sector in the country. All this with the promise of quality, affordable, personal health services for all Zambians based on their health needs. But how realistic is this, considering that the fact that the healthcare provision is complex and currently the health system is almost collapsing under the weight of a heavy disease burden. And for now, the promise does not seem to be good enough, as already the Labour Movement and Federation of Employers feel shortchanged by the way the scheme has been operationalized. A genuine concern or a mere lack of information. On Sunday Interview today, we feature James Kapesa, the new Chief Executive Officer for the National Health Insurance and Management Authority. Sir, welcome to the program.
Thank you, Grevazio, and good evening to our viewers.
Now, like any other new thing, you have to do a lot of explaining. And this includes explaining, unfortunately, who you are, what you have done, and what you have achieved to warrant this appointment as Director General for the Health Insurance Management Authority. Who is James Kapesa?
Grevazio, thank you very much. First of all, it's important that the public knows that the institutions are placed in capable and right hands. I'm a Zambian. I was born in a very small fishing town called Zambia, perched on a hill, and beside it, the Lake Bangwelu, where the sky seems to meet the waters. That's where I started my life. I then went to Bahati Minor Seminary in Mansard for my grade 8 up to 12. The intention was for me to become a Catholic priest, to be called to the holy orders to priesthood. As fate would have it, I didn't proceed. I normally blame my wife for not having gone to priesthood. And then from there, I proceeded to go and study accounting at the Copperbelt University. Now, it's important, Grevazio, for the public to know that for passers-by, accounting is synonymous with numbers, crunching numbers. But accounting is one of the best sciences that man has ever invented. Because what accounting does is that it looks at a process, at a phenomenon, at a system, and converts it to numbers. Because there are very few things about which man can agree, save for numbers. Your words can be misunderstood, misinterpreted, but when we agree that 2 is 2. So accounting is that field that tends to crystallize processes and concepts and phenomena into numbers. After completing my university at the Copperbelt University, I started work at a company called Industrial Credit Company in Ndola. We were one of the pioneers in vehicle and asset finance from Ndola. After that, I joined Stanbic Bank, and at Stanbic Bank, I cut my teeth in investment banking or merchant banking. The apex of my career at Stanbic was interesting. That's a time when Lumwana mine was starting, and I was a relationship manager in charge of the mines, besides other multinationals. A very heavy task for a young banker cutting his teeth. And I remember one day going to Lumwana and meeting Harry Michaels, who was the first managing director of Lumwana, in a tent, pointing to me that, James, where you see that huge tree is where the smelter will be. And I say, Harry Michaels, that's a muombo tree. I can only see a mukwa tree there. And he says, no, if you are able to see something which others haven't seen, that is leadership. So even as we start to talk about the National Health Insurance Authority, in its infancy stage, starting, we need to have skills that are able to see a smelter where others can only see a tree.
A muombo tree.
A muombo tree, yeah.
Yes. So in terms of expertise and experience, you're an experienced investment expert. I should call you an investment expert, a banker, and you have years of experience. Now, to move to the National Health Insurance Scheme, I want you to explain the basic meaning of what you are operationalizing. What does it entail? I know that health insurance means a lot of things, depending on where you're based, depending on your location, the country, and of course on what you want to achieve. What does this mean, health insurance scheme?
Gervasio, we need to cast the health insurance scheme in a very broad context in terms of Vision 2030, which is Zambia's collective aspirations as to what we will look like as a nation. Vision speaking to our true north, our guiding star, our dream. What is the collective position of Zambia as a 2030? Vision 2030 espouses a Zambia that is prosperous, a Zambia that is middle income. And prosperity is inseparable from health. And when you then look at the 7th National Development Plan, speaking to a productive workforce driving Zambia's development as a pillar of the 7th Development Plan, then you start to understand why we need to fix our health system. From the 7th National Development Plan, the Ministry of Health came up with a strategic plan that attempts to achieve several milestones, one of which is accepting that for us to solve and create better health systems, we need a financing structure that's innovative, meaning hasn't been done before. A financing system that's predictable, because once you start to predict your financing systems and structures, then you can achieve quality health care. So the National Health Insurance Scheme is a response to government desire to provide innovative and sustainable financing. What then is the concept around the National Health Insurance Scheme? What we're saying, Gervasio, and the public must know, is that we want to take advantage of the pooling effect of funding. We're going to each and every person in Zambia aged 18 and above and below 65. Those that are earning more and those that are earning less. Put these little bits of monies together in a fund. And because of the power of numbers, because the power of quantities, we are then able to get this fund as an authority, go to health service providers and negotiate a health package for you, which you could not have negotiated because you were alone. It does two things. It then means that where you were procuring a health service for, say, 50 kwacha, because of the law of numbers, I'm able to go and negotiate on your behalf as a member of the scheme, as a citizen, and I buy that service at a huge discount. And because I'm negotiating for you, you're assured of a standard healthcare package. And all you do is pay a predetermined premium, which is the contribution that we are asking for. Broadly, when we do this, we are then able to assure our citizens that they will have access to a standard, quality, and predictable health system.
That's what you're calling universal access.
Health coverage, yes.
Now, let's look at who is covered under this scheme. Who's eligible?
Gervasio, the scheme provides for mandatory contribution to the fund, meaning that every Zambian in the brackets that I've spoken to who is in gainful employment, and it's important that the public understands that this is beyond the 1.1 million workers who are in the formal sector, makes a mandatory contributions. Established residents in the country, working in the country, are also required to make a contribution. Those that are self-employed will also have to make a contribution into this pot, into this fund. And then once we've done that, Gervasio, then we're able to go and register members, meaning that every Zambian will have access to a basic health care package, which is the benefits that you're talking about.
In terms of who accesses the health services, once the workers and the employers have paid, then who is eligible to access the service?
Then what happens?
Because families are as big as 15, 10, 11, 12.
So what then happens, Gervasio, is that once we have registered you and we give you a membership card, the registration will be household-based, meaning that we now come to your household and register your members of your household. Now, universal health coverage has three principles, and it's important that we lay them on the table. Number one is universality. Number two is solidarity. Number three is accessibility, meaning that once you contribute to the scheme, we should be able to cover your entire household. What that means is that everyone has access. People are saying, but how are you able to do that? Remember, The 1% you're contributing is not the entire funding that funds the entire health system. We are not replacing government funding that comes from general taxation. We are just complementing the system.
You've explained that everybody is covered, but we've seen in some media where you have been quoted as saying only 4 members of a family will access the service. Is that the correct position?
No, that's not the correct position. The correct position is that the principal contributor, who could be you and your spouse, and we're also looking at potentially 4 to 5 on top of 2. It is about 6 persons who will be covered. Don't forget.
So if I have 8 children, 2 children are not covered?
Well, we're looking at the possibility of that being what we call case management. Case management meaning that there will be exceptions to making sure that everyone is covered. But broadly, finally, everyone is going to be covered under the scheme. Don't forget.
You've put 4 as a ceiling, and a bit on the unrealistic side, looking at Zambian families. A number of families don't go up to 4. Is that the real?
The position, Grivagio, is that the scheme is universal. The numbers that we are looking at, based on the benefit package which we have designed, which we'll talk about, ensures that, first of all, the scheme is solvent. The scheme must be as solvent as possible. But if you have more than the number of members that we're covering, the scheme will still have exceptions to cover you for that position.
Now, who is exempt in this in the payments? I mean, you've spoken about youngsters below the age of 18. These are exempt from the payments.
Yes.
Who else is?
What the Act also does, it looks at other categories of citizens that are unable to provide income and contributions. One of them is that all those that of unsound mental capacity will not be able to contribute to the scheme. They will be exempt. There are those who are above 65, like we said, but also there are those who are poor and indigent, those who are unable to earn an income. And remember that one of the core functions of the scheme is to provide access to health for poor people. In this case, we have ministries within government agencies that are able to share their database with us so that we are able to know that this person is indigent, this person is poor, this person is unable to earn an income. So those are exempt. But the Act goes further and empowers the minister to declare any other person exempt from the contributions.
Let's look at the promise. What are you promising people? I know that you've spoken about the money. The emphasis has been on the deduction and the 1%. What is the package? What are you promising? People pay quite all right. It's low now, but then what are you promising them in return?
Before we can look at the package, a very comprehensive package, we need to see in the context that the deduction is. The average income that we looked at in the numbers is about 5,000 kwacha. If 5,000 kwacha is the basic income we're looking at per contributor, 1% is 50 kwacha. If that 50 kwacha is stretched for 1 year, it's about 600 kwacha. But Grivazio, we can even go backwards and ask, what is 50 kwacha per day? 50 kwacha per day is about 2 kwacha. 2 kwacha is the money, Grivazio, that you put in your piggy bank, which we want to get from you, because probably you're still thinking about how to use it, and put it in the scheme. So for 2 kwacha per day, or for 600 per day, we are able to give you access
600 kwacha per year.
Per year.
Yes.
We're able to give you access to the following medical services. Number 1, you should be able to go to a hospital and receive consultations from a medical doctor within that contribution. You should be able to go and access laboratory services within that contribution. You should be able to go and receive medication, drugs, except those that are not on the list of prescribed drugs. And I'll talk about exemptions. So that is available should the doctor decide that you should be admitted. So the cost of you staying in a general ward, in a specialized ward, if the doctor decides to perform operations on you, if the doctor decides that you need to undergo surgery, that 600 kwacha covers you entirely. If you have a condition around your eyes, dental challenges, psychiatry, they are covered. Broadly, all these conditions. It's also important to now go down and name some of these diseases that are included in the benefit package. To arrive at the benefit package, what the team did is that they looked at the epidemiology of the country. What are the top causes of disease and death in the country? What constitutes the majority reasons why people visit hospitals? Number one on the list is malaria. It means that if you have a malaria condition, you will be covered. Pneumonia, chest infections, skin diseases, tuberculosis, diarrhea, all these are covered within the scheme. Broadly, we are covering every disease.
Maybe you should look at the exemptions. I know the diseases, the list could be wide. What are the exemptions?
The exemptions are based, again, on what the Ministry of Health has determined as, number one, is this procedure within the acceptable treatment protocol? Because there is a protocol that informs you how you would treat malaria, for example. If you visit a clinic and you meet a doctor, the doctor has a standard treatment protocol. A C-section in Zimbabwe is the same as a cesarean section in Zambia. So there is that protocol. So the following conditions are exempt. The first one is that we're contemplating that any evacuations abroad are not covered, because obviously we would like to encourage that as many operations and conditions are treated locally. What it does, it embeds capacity in our medical community. Secondly,
but by so doing, you are forcing capacity on development of capacity. It's not developed yet, and we've seen a lot of people being evacuated.
Like I said at the beginning, that this doesn't supplant what government is doing. So government, through the Ministry of Health, continues to provide the services that they're providing. But that one kwacha you are giving to us does not allow us to pay if there's an evacuation. Government may decide through its protocols to still evacuate you. We will not pay that. The other exemptions which are critical and important is that if you would like any cosmetic surgery, Grevajo, your one kwacha will not be applied towards that, because that's a personal choice. We're also saying that if there is a natural disaster, if there is a cholera, if there is an inundation, if there's an act of God, which is usually covered under the disaster management unit, that's already covered. We will not cover that. We're also saying that within the exemptions, government has a list of prescribed drugs available. And these are the drugs that are authorized to be dispensed in hospitals and private facilities. So if there's
even on the list of drugs, you have exemptions.
Yes, we have exemptions. But this is a very broad list of drugs and very, very few exemptions. The idea is that the treatment that we're offering under the scheme must be as cost effective as possible. Remember that this is your money, and for every kwacha we spend, for every kwacha we pay on your behalf, it's your money. We must be as judicious as possible.
Now, let's look at the hospital environment. You're talking about service, quality service, and people being able to access this. Currently, you will find a lot of shortcomings in our hospitals. No essential drugs. Sometimes in some institutions, x-rays are non-functional, and scanners don't work. So where do people access these things? They'll definitely feel shortchanged.
Not really, not really.
Address that.
It's a catch-22. We're saying that when the scheme comes, and it's important that we manage the expectations of our people, the scheme will not tomorrow change the face of our facilities. This is the first step we're making to a statement, a very bold statement, meaning that as we implement the scheme, you start to see changes in the availability of drugs in the hospitals. You start to see changes in the quality and speed and effectiveness of treatment, because within the structure of the National Health Insurance Authority, there is an inspectorate team, which means that if you are a facility that is accredited to us and you receive payments from us, there will be periodic visits by our team to come and check whether, number one, you are adhering to the protocols that we have signed in our MOUs, that the facility and quality of care is within the protocols. So over time, you start to see transformation in our healthcare facilities. You start to see transformation in the availability of drugs and healthcare services. Now, you might ask, but James, you can't control when there is no power and so your X-ray is not working. Sometimes you might have a challenge in the supply chain of the drugs. Are you guaranteeing that you'll have 100% access to the drugs? What the National Health Insurance Scheme has done is look at a multi-sectorial approach to solving this national challenge. In short, we're also speaking and contemplating ability to accredit pharmacies, ability to accredit laboratories, meaning that the doctor is able to give you a prescription. The only difference this time, Grevajo, is that instead of asking you to go and look for money out of your own pocket and pay for the drugs, you can present that prescription to an accredited pharmacy, an accredited laboratory, and the authority will pay the bills on your behalf. So in short, we've looked at the entire value chain and asked ourselves, where could we have a glitch? Can we bring partners on board? And in this way, the fear that you have heard from private hospitals is unfounded, because this scheme brings them on board as partners, but also, very important, brings additional traffic and business to the private health community.
Now, let's look at one other issue. You've spoken about changing drastically, changing the way health services are delivered, and progressively. But let's look at the money that you're anticipating to make. In some sections, you've been quoted as saying 1.2 billion kwacha annually, and that's looking at 17 million people. That's not enough. That cannot guarantee quality health service, universal quality health service.
Grevajo, you look at it from another angle. And the other angle is that the National Health Insurance Authority, the National Health Insurance Fund, does not supplant or replace existing government funding to the Ministry of Health. So see it as an intervention that complements the existing government. Government continues to provide primary health care. In fact, in terms of our implementation strategy, we will start with first-level hospitals, second-level hospitals, and third-level hospitals. And for the layman, these are district hospitals, provincial hospitals, and referral hospitals. Besides that, what we're doing is innovative. When I receive that, say, 1 billion, 1.2 billion kwacha, I am able to put it in a fund. And the actuarial evaluation allows me to invest that money which is not yet out into use, to create additional cover for 1 or 2 rainy days. Then using that money, Grevajo, which if it was in your hand as 1 kwacha, it could have probably bought 1 unit of medical treatment, for argument's sake. But because I have a pool of huge members who I will push through your hospital, what then happens is that instead of that 1 kwacha buying 1 unit, because you can't negotiate, my 1 kwacha can buy, say, 4 units of medical services. So see the authority as this huge public institution with capacity to invest your fund and push for economies of scale. Because I know, first of all, internally, that I know the cost of a C-section, because there will be doctors sitting as experts in the authority. We've done a detailed costing of all the procedures. And then I'm able to go and negotiate for you and make sure that your 1 kwacha, which was only worth 1 unit of health services, because it's in the authority, it's now worth 3-4 units. So I can multiply the loaves of bread, if you put it that way.
We are looking now at affiliation, accreditation. This is a law, and people are asking, there are a lot of people on private health schemes. Why are you forcing them to go into a public health scheme? They're already covered.
Yes, they are. And
you could as well leave them there and allow them to access the services they need.
Yes, they are covered. And what we are saying is that the scheme is mandatory. You still contribute your 1%, and you still continue to subscribe to the private health funds that you're doing. And
is there any reason why you're forcing people? Because your initial intention is to ensure everyone is covered. But you have this 3.9% of Zambians who are already covered. Why don't you just forget about them? They're already covered.
Gervasio, remember that this is about government providing universal health coverage to all its people, and universal health coverage sits on 3 vertices, 3 points, one of which is solidarity. It's government's task, sacred duty, to provide health care as a basic right, basic health care as a basic right. And how do we finance that? And so this way, the National Health Insurance Scheme is a way to try and finance the extension of health care beyond the 4% or beyond the 1.1 million workers who are already covered, to cover everyone. Now, remember, Gervasio, that if you are in an island of premium health, 4%, and the other 96% are struggling health-wise, in the longer term, you will be affected as well. Not too long ago, we had cholera in high cost areas. We had cholera in upmarket, food outlets. The cholera was not coming from you and me who stay in Kablonga or in Northmead, because out there, the majority are not covered. So by us thinking that we are safe within our own private medical schemes, that doesn't provide sufficient protection for you as well. So what we're doing, Gervasio, is trying to broaden the healthcare net so that 2 things happen. The first thing is that over time, your cost per unit of accessing healthcare services will reduce. So it's actually not a tax. This is a subsidy we are giving to you over time. Secondly, what is happening is that because in one of the studies we did, the number of days on average a Zambian in 2016 spent at the hospital was 5 days. That's huge productivity lost. With the scheme coming and supplementing government efforts, imagine we have that 5 days to 2.5 days. The level of productivity in terms of GDP, in terms of less absenteeism, goes back and sits on the employer's profit and loss statement, meaning you can do much more business, meaning you can make much more profit, meaning that the general outlook of the economy with a healthier and more productive workforce through this scheme is very bright. This is a win-win situation for employers. This is a win-win situation for government, even for households.
Let's look at your targeting. I mean, we're talking 1.1, 1.2 million people in formal employment, and there's a huge number of people in the informal sector. How do you intend to capture this? It's one of the major concerns, that you'll have a few members of the public burdened to subsidize and support the health system.
Let me make it clear to the public, to the citizens, that in terms of implementation, we will start with those that are in formal employment. This would be your civil servants, those that are in quasi-government institutions. We're also looking at starting with those that are in the formal sector. That is phase 1. And this number of people is about 1.1 million. The labor force survey of 2017 suggests that another 6 million people are out in the informal sector. And so one of the key tasks of the authority is to partner with existing agencies like NAPSA, like ZRA, and many others. It's to partner and forge links with associations in the markets, to go and speak to groupings with cross-border traders, to go and speak to small-scale farmers, and create a platform, create a system, which we're working on, that goes and collects contributions from those, put it in the fund. Now, is it easy, Gervasio? It's not easy. But you see, until the nation galvanizes its ideas and minds and resources towards one goal, it won't be achieved. So the authority...
But you're looking at 600%, I guess, of the people outside the formal sector. 1.1 against 6 million who are not in the formal sector, and already the institutions you are mentioning, ZRA, NAPSA, they've equally been struggling to capture this informal sector. How sure are you you're going to succeed?
Success, Gervasio, is never an overnight structure. They have started. We will put our heads together, we'll put our concepts together, but this strategy of bringing universal health coverage to our people, we do not think it's going to happen in year number 1. In year number 1, we would have laid the foundation. It may not happen in year number 2. We're very confident. Remember that the plans to start the National Health Insurance Authority are as old as 2008. A lot of data has been collected. A lot of strategies have been put in place. The first actuarial evaluation, Grevaggio, was done in 2008 for implementation in 2010. It wasn't done. The second one was done in 2012 for implementation in 2013. This is 2019. Within these studies, you have tactics, you have strategies that attempt to solve that problem. And this is why you have a management in place under the National Health Authority to sit down and assess the environment and attack this problem. For now, you don't look convincing that you're going to attack the informal sector. We are very convinced.
Making the allegations, not allegations, concerns by the public sector that it's going to hit them bad, and they're going to shoulder the burden of looking after the health of everyone in the country. And they're only 1.1.
The assurances to them is that we are convinced that in terms of implementation by September, October, we will have done the logistics around phase 2, which is the engagement with the informal sector. And what makes us more convinced than ever is that the response we've gotten from the informal sector, Grevaggio, you'll be silently surprised that they are keener, they are eager to start the contributions. They are ready to go, of course, because they have had questionable access to health. So whilst in other institutions which would go to them to collect resources, there's probably no direct linkage to a benefit. For example, if you're collecting taxes, if you're collecting pension, the promise is for a pension payable after X number of years. What makes our scheme more proactive, Grevaggio, is that there's an immediate and almost identifiable benefit available to that member as soon as our window period starts. Because of that, we're very convinced that this is a slightly different product with higher expected compliance levels.
Isn't that a wrong premise, considering that for the first year, those in the informal sector will almost enjoy free health care, supported by other people who are in the formal sector? And you expect them in the second year to just turn around and support the whole?
Grevaggio doesn't work like that. In terms of the modus operandi of the scheme, is that we will come and register you at a stand where you operate, where you are selling phones, at a shop. We'll come and register you, we'll give you a card, and with that card we will load onto the card your dependents, and then they start to access healthcare services. You asked the question, what about those who have not yet been registered? Grevaggio, this does not supplant government efforts. They can still continue to access healthcare facilities. In short, what we're saying is that this is a phased approach, and we decided that we need to phase it because the chances of succeeding in project management when you have phased your implementation are higher. We owe it to our people that this succeeds because we have a chance to change the health geography of our people.
Let's look at issues of compliance in terms of remittance. I know that companies like the Workmen's Compensation, NAPSA, ZRA, all suffer this problem of lack of compliance. Institutions don't remit what they collect from their workers. Will this be different with you? Have you planned around this problem?
Yes, we have. In our financing strategy, in our financing objectives, we have had to look clearly at what levels of delinquency, what levels of default are possible and plausible. But before I delve into that, that's a management task. Every business, every process has risks. And that's why the board decides to put a management that is multitasked, multi-talented, with vast experience across medicine, across accounting, across insurance. Bring them together under my leadership to make sure that when we confront a problem around delinquency, when we confront a problem around compliance, we are able to mitigate those problems so that they do not impact adversely on the outcome. Remember, I talked about our investment team. There will be an investment team in the authority whose sole purpose is to make sure that any idle funds that you have entrusted to us are sweated, they are put to good use, so that on a rainy day, when there's that unexpected delay in collecting money from ZNBC or from government or from the mines, our members are not inconvenienced. The services continue to flow. So compliance is a management risk, and when you look at our structure, the structure of the organization is designed in such a way that you have a team, a department that is consistently using the force of law, cohesion of law, to induce compliance. We've also got a team that speaks to the benefits of complying, meaning that our compliance levels are going to be better. But should our efforts to attract compliance fail, the Act has given us capacity to go in as inspectors and mete out punishment. So we will be balancing justice and cohesion. We will be talking to our members to understand the benefits. And that's why, as we speak today, we have launched a massive awareness campaign aimed at making sure that our self-compliance, is higher. Our people are able to come on their own to pay because they see the benefits for themselves and their children.
You're talking compliance and you're talking about using the force of law to ensure people comply. But you've forgotten one major culprit. Government is a culprit too. Quasi-government institutions are culprits. Ask ZRA. They'll tell you that you have a lot of parastatals that don't settle their date.
Gravaggio, this is a new page, and like I said to you, the difference here is that there is a direct benefit, and the benefit that you're getting from the scheme is almost immediate.
How are you going to force compliance on government institutions, on ministries, and on public service workers?
Gravaggio, what we've done in terms of structuring of we have a board of directors that is across all sections. We will intend to use their networks, their contacts. We also have, in this particular case, like I said, systems and structures that deals with that as a matter of non-payment. If government hasn't paid their 1% on the gross civil service bill, that becomes a collection strategy. In accounting, Gravaggio, there are 2 points that you should never mix together. The first point is creation of revenue and income. And this is what the Act has created, or in a private company, invoicing. You should not stop invoicing because you think that the customer will not pay you. So the invoicing part is point number one. So we will invoice, we will expect payment. The collection point is another point where now you say, how do I make sure that lack of collections does not impact my operations? This talks to, number one, making sure that collection strategies are in place, making sure that we are not wasteful in the use of our resources, making sure that we negotiate a better package, and making sure that, Gravaggio, the little resources that lie idle before we use them are multiplied.
No, I'll leave that aside, but I know that government always has challenges paying on time. You've got, sometimes they owe farmers, sometimes they owe contractors, and they'll definitely owe you.
We don't think that date is a reason why we should not commence this process. We are of the view that date is a normal occurrence in a business. We will not be scared dead because ZNBC hasn't paid us. We will put in place structures that, number one, collects that money. If we haven't collected it, Gravaggio, create other value chains that does not cast aspersion on our integrity as an authority. Remember, it's important that when a private hospital sends a bill to me, I pay that bill within the agreed time frame. The moment I start to delay that, then the authority starts to lose integrity, and the dream of universal health care across all facilities evaporates.
Collapses. Let's look at consultations. You've spoken about this issue being on the table for over 10 years now, 2008, 2010, 2013. But still we have outcries, key stakeholders, Federation of Employers, Congress of Trade Unions, representing the mass, that is critical mass that is supposed to push your agenda forward. They've said they were not consulted enough, that you have not taken on board their concerns.
Gervasio, the nature of a process of this scale is such that it's very difficult to come this far without consultations. Let me start with the process of creating the actuarial report, which in itself is the basis on which government decided that this is a good business case. The actuarial report of 2008 has a list of partners, as a list of participants, as a list of institutions who were consulted in arriving at that process. That is consultation. Come to 2012, the actuarial report of 2012 again went back to stakeholders, including those that are saying they were never consulted, and asked them about their input. Let's come to the enactment of the bill. Again, you notice that embedded in the process of arriving at a bill and then into law, you cannot have a bill enacted into law without consultation. There was massive consultations, but what I can share with the nation...
You could have consulted, but you probably haven't picked their concerns and taken them on board.
Let's arrive at that position. There are two things that happens in a consultation. There is the vision carrier who carries the vision, who comes for consultation. Three things are possible. The first position is that your advice, your input is uplifted into the process in all. There's a possibility that your submission can be re-amended to fit into the picture. There's also a possibility that your submissions are not included for that particular time for future implementation. What then happened in this process is that some of the stakeholders who are saying they were never consulted took a position that they will not get involved in this process. They were invited. They declined to be part of the process because they are saying that their issue is with the Act. Because the Act is now fully embedded, they will not engage in consultation. We have two positions as an authority. We are open for dialogue. We're open to receive feedback. There is a possibility and window that if the issues raised have to provide further and additional value to the outcome of universal health coverage, there is a possibility that stakeholders can come through the normal channel to look at the Act. But we must start. Remember, you cannot perfect a system from the stands. We have to start.
You want to start without carrying the key stakeholders on board, no, the interest groups on board. ZCTU, for instance, they say, well, I agree with you, but they will not support you on this one.
The issue that stakeholders like ZCTU have raised are issues which we have looked at, and we are of the view that they do not materially affect the outcome of what we are looking at, universal health coverage. For example, the discussion is that, is this a labor issue or is it a health issue? Those are some of the issues that are on the table. And the Ministry of Health and the National Health Insurance Authority are saying this, whilst it encompasses workers, and workers are very critical. ZCTU is a critical partner. So is Zambia Federation of Employers. Yes, workers are involved, and it's a constituency we're going to start with. This goes beyond workers. It becomes national, and it's health. Number two, there has been debates whether this should sit in one institute, in NAPSA, or it should sit on its own. There are debates whether there is capacity in the Ministry of Health to handle this. And our view is that the drafters and the conceptualizing of this Act is that there must be a separate body corporate, which is your authority, which runs this. And Gervasio, it's important that in many countries where this has been implemented, the Ministry of Health has carried out visits to these countries. We have had exchange visits. We've been to Ghana, we've been to Rwanda to look at how this has been done. And we can assure the nation that the template that we are trying to roll out is a tried and tested template.
From Ghana, from Rwanda?
Yes.
Hybrid?
It's exactly, obviously we have to customize it to our localities and our nuances. But the bottom line is that in these countries where the scheme has been implemented, where we went to learn from their mistakes, the template that we are rolling out is a tried and tested template.
Employees are saying, public service workers are saying they have not signed a collective agreement that factors in the deductions that you want to start at the month end. Is that a valid argument in your view?
Gervasio, the complete position in terms of which speaks to the 1% contribution, how did we arrive at the 1% contribution, is that in 2018, the unions and government signed a collective agreement and agreed on a 1%, because the contributory rate on a scheme like this comes from two sources. The first source is that experts in actuaries who did the 2012 actuary report and subsequent reports were very clear that we needed a higher contributory rate. But because of the consultative nature of this process, the unions with government during the 2018 collective agreement proposed a 1% contribution rate with a proviso, Gervasio, that before this is implemented, we should share with them what will be contained in the benefit package. What is the 600 kwacha per annum I spoke to you giving them?
You have not shared with them.
Hold on. Will the 600 kwacha be enough? And remember, let us take 6 people as, and it's an open debate. Let us take a household of 6 people, and they contribute 600 kwacha per annum, or 100 kwacha per annum. The unions and stakeholders were saying, what is the list of services that we are going to access? How much money would that cover? And we went back to them on more than 2 occasions and say, this is the list of services, the ones that I've tabulated here. This is the list of services that are available. In universal health coverage, remember, you cannot limit a figure because the 1% is not the only money that I have. In a private health insurance scheme, the 1% or the 2% is the only money. So there is a limit of how many times you go to the hospital. There's a limit of how many cesarean sections you should have. We've gone to the stakeholders and said, broadly, these are the list of services that are provided at a district hospital, at a provincial hospital, that are available for you. And, Gervasio, these are the list of services that are exempt. Now, some of them have asked for more details. And we're saying, the further the detail, the more you are trudging in management realm. That is a management matter. And allow us to start, because this is just a basic health package.
So you have not agreed on the package?
No,
with the unions. You have not agreed. And the unions are telling you, you have not given us the package, and you want us to pay.
On the 2-3 occasions we've met the unions, we have shared with them the same list of services that I've shared with you. Their request has been, how detailed can it be? And our debate has been, look, the details, the minute details, back office issues. We are assuring you as a public that if you go to Chilenge First Level Hospital with a card, and we will soon be publishing the benefit package, when you go to Chilenge with your card, you will not be turned back unless you want a facial change. You will not be turned back until you want medicines that are not on the prescribed list. Broadly, the broad conditions that cause the top 10 reasons for morbidity will be covered. So, in our view, the broad spectrum, circumference of the benefit package is available and has been shared with the union. The details which are backroom issues are the things now you go and start to perfect once you're on the ground. Gervasio, there's no battle strategy. There's no war strategy that is perfected in the drawing room. You have to go on the battlefield. And that's been our debate. That's been our argument. So our view is that broadly, there is consensus on what is available to the members.
But you have a few issues on the specifics. Let's move on. I believe you've got you're facing trust issues even before you start. And people think, well, one of the fears is that this money will go towards initially buying yourselves expensive vehicles, paying yourselves very good salaries, and probably trips, workshops, and allowances. And then before everybody knows it, you'll be back asking for an increment from the 1% to 2 or probably 5%. Is the money secure?
First of all, it's gratifying to know that the public have heightened interests in the National Health Insurance Authority. Grivaggio, that in itself affords us no chance at all of any impropriety. Heightened interest in public affairs, because they know it's their money. So for us, we welcome this heightened interest and concern that every kwacha that is collected is put to proper use. Going further, we have in the National Insurance Authority systems and structures that are designed at inception, not once the horse has bolted. Our design of the processes and systems are such that we should be able to detect and manage fraud and risks upfront, so that as the process goes, we have less work for our internal auditor. But we also have an internal audit department. What the board did at its last meeting is that it insisted that the audit department, audit and risk department, must be a full department and properly resourced, properly staffed, so that it can act as a watchdog internally when things are happening to safeguard interest of the people. The act is also very clear, and under my watch, production of financial statements and reports, one to the board and to the minister who places these reports on the floor of parliament, would be non-negotiable. Remember, we also operate under the Public Finance Management Act. It's got very strict, oversight laws. The fiduciary nature placed on us, the fiduciary duties and expectations are high. So you have legislation, you have internal systems, and you have a public that is alert. These things put together with our values as an authority should assure the public that it's possible to run an institution which answers to the people and which delivers universal health coverage.
Finally, Mr. Kapesa, you start receiving public money in the next 1 to 2 weeks. And when do people see the benefits?
Very important, Grivaggio, again, that the business case for the National Health Insurance Scheme comes from an actuarial valuation. The actuarial valuation had several permutations. One of the permutations was that if we rolled this scheme to all the civil servants and private sector employees, how much money do we need before we can start to deliver services? So there's a 4 months window period. In this 4 months window period, Grivaggio, it means that we will be reserving funding, we will be perfecting the systems, we will be dealing with the issues that stakeholders have raised, so that come 1st November, the systems are perfect and we're good to go. So every contribution that starts now has a 4 months window period before you could access the facility.
Accreditation has started?
But it's very, very important, and Grivaggio, to also note that once you have ceased to be a member of the scheme for various reasons, and as the system is about to move you out, you have that 4 months window period. For example, if the main contributor dies, we do not move you out of the system immediately. We use the 4 months period, which you had contributed, to make sure that the exit is as smooth as possible. Accreditation. Accreditation has already started. Remember that we are not reinventing wheels here. There are agencies in the Ministry of Health, like the Health Professions Council of Zambia. They are in charge of accrediting health facilities, both public and private. Right now, there are about 110 district, provincial, and referral hospitals. We will start with these as phase 1. There are about 458 private hospitals, but for those that are in this category, there are about 50. So we're looking at 150 facilities in phase 1. This is work, according to our work schedule, which is a very tight work schedule, is work that can be done within the next 30 days. 60 days. So within the 4 months that we've proposed as a window period, the public is assured that we will be more than ready to roll out this project.
Mr. Kapesa, it's been a pleasure having you on the program.
Grivajo, thank you very much.
You've been watching Sunday Interview, and that's all we have for you this evening. Our guest was the Director General, National Health Insurance Management Authority, discussing the National Health Insurance Scheme. We'll be back next week sometime. Pleasant viewing.